Hello, everyone. Welcome to another session of Zooming Through ID. I'm Dr. Gopal, an infectious disease specialist who has been practicing in South Florida for a little over 20 years. I trained at Duke University. Um, I am very passionate about teaching, and Zooming Through ID is an opportunity that I've created when residents rotate with me. They pick a topic of interest and they showcase it as the presentation, and they learn most from this experience. I do chair the antibiotic stewardship for the four district hospitals, and I'm also the chair for infection control. We are joined today by our first fellow. We do have a fellowship program, Infectious Disease Fellowship program, and I'm an APD for that. Uh, we have Amir here. He's joining us. So Amir, can you introduce yourself a little bit and talk about yourself?
Everyone. Hello, everyone. My name is Amir Zayzoun. I'm the PGY4 Infectious Disease Fellow at Broward Health North. Joining here, Dr. Gopal. She is our Associate Program Director. We'll have an interesting lecture today with our residents.
Okay, so we are Sneha is going to present about urinary tract infection. So Sneha, can you introduce yourself and then
Yes.
you can start your
Okay.
presenting. Yeah.
Hi, everyone. My name is Sneha Polam. I'm a PGY1 in internal medicine at Broward Health North. I completed my medical school at NSU KPCOM in Fort Lauderdale. Overall, I'm interested in cardiology, but I'm also very passionate about antibiotic stewardship and proper antibiotic management. So I'm very happy to be here and give this presentation on UTIs. I'm going to share my screen. Okay, can everyone see?
Yes.
Okay, perfect. So urinary tract infections. So I'm going to go through these different topics. So the pathophysiology, clinical presentation, diagnosis, management, prevention, and then we'll go through a case and then some board review questions. So UTIs, so there's two different types. So the first type would be cystitis. This is just the infection of the bladder and the lower urinary tract, But there is also pyelonephritis, which is infection of the kidney or the upper urinary tract. So cystitis is very common in women, but less common in men, but the incidence in men increases with age. About 1 in 2 women will experience a UTI before the age of 32. And risk factors of UTI include history of prior UTIs, sexual intercourse, use of spermicides, diabetes, structural and functional urinary tract abnormalities, and then lack of circumcision in men. So the different types of UTIs are acute simple cystitis. So this is a UTI that's confined in the bladder of a non-pregnant individual. So acute simple cystitis does not present with any systemic symptoms such as fever, pelvic or perineal pain, flank pain, or CVA tenderness. It's less common in males because males have longer urethral lengths, they have more dry periurethral environments, and the prostatic fluid includes antibacterial substances. While acute complicated UTI is a UTI that has features that indicate infection beyond the bladder. So that would include more systemic symptoms like fever, flank pain, and CVA tenderness. And so patients with underlying urologic abnormalities like nephrolithiasis or stricture or immunocompromising conditions or poorly controlled diabetes, these people are not considered to be complicated UTIs. And then asymptomatic bacteriuria is when you have isolation of bacteria in a patient without any symptoms of UTI. So these are more common in older patients, and non-pregnant patients should not be screened or treated for asymptomatic bacteria. Asymptomatic bacteria should only be treated in pregnant patients, patients that are undergoing urological procedures where mucosal bleeding is anticipated, or patients who have recently received a renal transplant. So how does a UTI even occur? So bacteria from the fecal flora usually, or uropathogens from the fecal flora colonize the vaginal intrauterus or the urethral meatus, and then it ascends through the urethra to the bladder. So as the bacteria continues to ascend up the urinary tract, it can cause a complicated UTI. So UTIs are most commonly caused by E. coli, followed by Klebsiella, but other common pathogens are Proteus, Staph Staphylococcus, and Enterococcus. And patients with recent antimicrobial exposure or healthcare exposures you should consider Pseudomonas, Enterococcus, or Staphylococcus. Some possible contaminants could be lactobacilli, enterococci, group B strep, and coagulase negative staphylococci. And there have been increasing rates of antibacterial resistance in E. coli reported globally. And some risk factors of this include recent broad spectrum antibiotic use, healthcare exposure, or travel to any regions where multi-drug resistant organisms are prevalent. And there have been increases in ESBL producing isolates throughout the world. So how do UTIs present? So acute simple cystitis is when symptoms are confined to the bladder. So this includes dysuria, urinary frequency, urinary urgency, and suprapubic pain. While acute complicated cystitis is when a patient has symptoms that suggest extension beyond the bladder. So this would be more systemic symptoms like fever, chills, rigors, fatigue, flank pain, CVA tenderness, or any pelvic or perineal pain in males. It can also present with bacteremia, sepsis, multi-organ system failure, shock, or kidney failure, and can be associated with transurethral, suprapubic, or intermittent catheterization. So how do you diagnose a UTI? So the diagnosis of acute simple cystitis can be based on just urinary symptoms. So that would be the dysuria, the urinary frequency, the urgency, or suprapubic pain. But this diagnosis can be supported by evidence of pyuria and bacteria on a UA or in a culture. So how do you collect a UA? So the best way to collect it is avoided midstream urine collection, and that's how you would evaluate for pyuria. You can also use a dipstick to evaluate for pyuria, and leukocyte esterase would indicate pyuria, and nitrates would indicate the presence of enteric bacteria. And when you examine a UA, you want to see greater than 10 leukocytes. That would indicate a UTI. You can also further characterize a UTI by doing some imaging. So you could do a CT or a renal ultrasound to determine if there's any anatomical or physiological factors that are contributing to the UTI. So there has been a change in the classifications of UTI recently. So the old classifications were when there is uncomplicated UTI in afebrile, non-pregnant, premenopausal women, and that consisted of an uncomplicated UTI. And acute pyelonephritis was when there's a kidney infection in women, otherwise meeting the definition of an uncomplicated UTI. And then complicated UTIs would include any other UTI, meaning that any UTI in men was automatically considered complicated. But now, all uncomplicated UTIs are infections confined to the bladder in both afebrile women and men. And complicated UTIs are just any infection that extends beyond the bladder, so in men and women. So all pyelonephritis, all febrile or bacteremic UTI, and all catheter-associated UTIs would be considered complicated UTIs. So in terms of the management of acute simple cystitis, so first you want to look at what are the symptoms. So if the patient is presenting with dysuria, urinary frequency, urgency, or suprapubic pain, and you see pyuria on a UA, you can consider that acute simple cystitis. Now you also have to look if the infection is extending beyond the bladder. So are they febrile? Are they presenting with flank pain? If they're not, and there's no risk factors for MDR, which would be, staying at an inpatient healthcare facility or using a broad spectrum antibiotics or any travel to parts of the world with high rates of MDR, multi-drug resistant organisms. If there's no risk factors for that, you can treat them with nitrofurantoin, Bactrim, fosfomycin. But if there's any reason to avoid any of those, you can treat them with amoxicillin, cefpodoxime, cefdinir, or if there's any reason to avoid beta-lactams, you can treat them with fluoroquinolones like ciprofloxacin or levofloxacin. And if you're outpatient and you're managing an acute complicated UTI, if there's no MDR risk and there's no concerns with fluoroquinolones, you can treat them with fluoroquinolones. But if there are concerns for use of fluoroquinolones, like if the patient is elderly or if they have a prolonged QTC, you can treat them with Bactrim. You can treat them with amoxiclav or cefpodoxime or any of the ceftriaxones listed below. If there is MDR risk, you can treat them with 1 dose of ertapenem, 1 gram IV, and then you can follow that with fluoroquinolones. And then if you're treating a complicated UTI, if the patient has sepsis with or without shock, you can treat them with 3rd or 4th generation cephalosporins, carbapenems, or Zosyn, or fluoroquinolones. If they do not have sepsis and you want to do an IV route of therapy, you can do the 3rd generation or 4th generation cephalosporins, Zosyn, or fluoroquinolones. And if there's no sepsis and you want to choose a PO route, you can do Bactrim or fluoroquinolones. So for hospitalization of acute complicated UTI, so if the patient is hospitalized with critical illness like severe sepsis or acute urinary tract obstruction, you can treat them with anti-pseudomonal carbapenem like imipenem or meropenem plus vancomycin. And if they're hospitalized without any critical illness, like without severe sepsis or any urinary tract obstruction, and there is no MDR risk, you can treat them with a 3rd generation cephalosporin like ceftriaxone, or you can treat them with a fluoroquinolone. If there is MDR risk, you can treat them with Zosyn, cefepime, or any anti-pseudomonal carbapenem. And also, the indications for hospitalization for acute complicated UTI would include fever, sepsis, if they're critically ill, if they're unable to maintain any oral hydration or take any oral medications, or if there's any obstructions suspected. So let's say the patient's in the hospital and you want to discharge them and you want to switch them and you're thinking of switching them to a PO medication. So you would first assess if the patient is clinically improving. If they are clinically improving, you would assess for some oral options. But if they're not clinically improving, the first step would be to assess for any drug-bug mismatch or to assess for any unresolved source of infection, reassess the complicated UTI diagnosis, or plan for a longer course. If they are clinically improving, you would assess for oral options and then switch to the oral agent and then treat for 7 days total of antibiotics. So duration of therapy. For uncomplicated cystitis, you can do 3 to 7 days depending on the antibiotic choice. Some antibiotics prefer a longer duration. For acute pyelonephritis, you can treat the patient for 7 to 14 days depending on the antibiotic choice. If the patient has a complicated UTI or catheter-associated UTI, you can treat the patient for 5 to 7 days. And then if the patient has acute bacterial prostatitis, the treatment duration would be 2 to 4 weeks. And the antibiotic treatment therapy should be determined, the duration should be determined based on each clinical case. So there's not one hard or fast rule. So recently, the IDSA came out with guidelines on management of antimicrobial resistant gram-negative infections. So infections caused by ESBL-producing Enterobacterales or AMC-producing bacteria or carbapenem-resistant bacteria or any Pseudomonas with resistance or any carbapenem-resistant Acinetobacter, they recommend first consulting ID. And if you have a patient with ESBL-producing organisms, you can choose carbapenems, cefepime, or Zosyn, but Zosyn and cefepime are less preferred. For AMC-producing bacteria, so the pneumonic Heck-yes, you would choose cefepime, but carbapenems can be used for more resistant cases. If you have bacteria that is carbapenem resistant, you can do ceftazidime avibactam, or you can do meropenem, avoribactam, or imipenem, relebactam. If the patient has a DTR Pseudomonas producing bacteria, you can do ceftazidime, avibactam, kind of the same bacteria as or same antibiotics as the CRE organisms. And then the other ones are listed below. So the crab bacteria, you could do sulbactam, durlobactam, and then the Stenotrophomonas maltophilia, you can do Bactrim. So there are some adverse effects to consider when treating patients with UTIs. So nitrofurantoin can cause GI upset and headaches. Bactrim can produce rashes, GI upset, hyperkalemia, SJS, and you should avoid Bactrim in patients with sulfa allergies or any renal dysfunction. Fosfomycin can cause GI upset and headache. Fluoroquinolones, you should look for any QT prolongation, tendinopathy, C. diff infection, or aortic dissection in these patients. And for aminoglycosides, you want to be especially careful in patients, or you want to look for any symptoms of nephrotoxicity or ototoxicity.
Just couple of additional points. I mean, for the nitrofurantoin, one of the rare toxicities that we see is the pulmonary toxicity. It is acute reversible hypersensitivity reaction. So we see that with nitrofurantoin. Okay.
So some complications of UTIs include prostatitis, epididymitis, and orchitis in the lower urinary tract, while in the upper urinary tract you can see pyelonephritis, renal or perinephric abscesses, and renal scarring. Systemic complications of infections or systemic complications of UTIs would be bacteremia or urosepsis. And some special situations to consider with UTIs are catheter-associated UTIs, any UTIs associated with ureteral strictures, or patients who are pregnant with UTIs. Some more common complications are prostatitis. So prostatitis can present with pelvic or perineal pain. Also pain radiating to the tip of the penis or any obstructive symptoms like hesitancy or dribbling. And pyelonephritis can present with fevers, chills, flank pain, CVA tenderness, nausea, and vomiting. And catheter-associated UTIs can present with systemic symptoms, fever, suprapubic tenderness, and CVA tenderness. So how to manage urinary catheters. So patients who no longer need long-term catheterization should have their catheters removed. And patients who are in the hospital you should constantly evaluate if they need their Foley that is in place, if they need it every single day. Those who require extended catheterization should undergo intermittent catheterization if possible because it's associated with lower rates of bacteria. And if long-term catheterization is needed, it's recommended to remove and replace the indwelling catheter with a new catheter at the initiation of antimicrobial therapy or when submitting urinary samples for testing. And there's no clear benefit for any use of antimicrobial-coated urinary catheters or prophylactic antibiotics at the time of catheter placement. So prevention of UTIs. So they recommend high fluid intake, 2 to 3 liters of fluids a day, postcoital voiding, any contraception modifications. So, use of spermicides or infections, or basically use of spermicides during coitus, and then wiping from front to back to avoid any perineal contamination. Any use of topical vaginal estrogen in postmenopausal women. They also recommend using methenamine hypourate, 1 gram BID, or cranberry juice. And you can use postcoital antibiotic prophylaxis. So now we'll discuss a case. So there's a 77-year-old male with past medical history of hypertension, type 2 diabetes, presenting to the hospital with 4 days of dysuria and urinary frequency. He states he had an elevated PSA and urinary retention, so he saw a urologist who performed a prostate biopsy 1 week ago. Now in the ED, he's found to be febrile with a temperature of 38.4 and leukocytosis with a white count of 20. Blood cultures and urine cultures were drawn in the ED, and the patient is then admitted to the hospital. So at this point, what antibiotics would you start the patient on? and this is his UA.
So usually he has elevated leukocyte esterase. It's large. We have the WBC 13.
Mhm.
Yeah, probably there's no, you don't put any options.
No, this is just
Yeah, so exactly. So I mean, in this case, you know, it could be like most likely it is acute bacterial prostatitis. So probably we will need some coverage, like broad spectrum coverage for gram-negative plus Pseudomonas, Enterococcus. So I would go like with something like cefepime or meropenem. I think to
That's
cover for prostatitis. Yeah.
Yes, that's perfect.
Very
So
good. Very good. Yeah.
exactly. So now his urine culture is growing Klebsiella pneumonia, ESBL. And additionally, his blood cultures are also growing Klebsiella, ESBL. So I know you chose cefepime and or meropenem. Which antibiotics would you keep or de-escalate based on these findings?
Yeah, I mean, of course, for the Klebsiella pneumonia ESBL, we'll go with the meropenem.
Perfect.
Yeah.
Exactly. So this patient was placed on meropenem, 1 gram IV Q8, until he eventually improved clinically, and then he was discharged on meropenem outpatient. And this was his susceptibility. So his Klebsiella pneumonia ESBL that was in his UTI and in his bacteremia was susceptible to meropenem.
Yeah. So this is very nice. I mean, I'm glad that Sneha brought this case because it is well described that people who get prostate biopsies, they often get a transient bacteremia, and usually they get chills, fevers, and that's exactly what this patient had. Sometimes they get some antibiotics prior to the procedure. I am not sure whether this patient got Cipro or anything prior to the procedure because they do a urine analysis and then look at it. If they don't do it empirically, Livoquin or Cipro is usually given. And then this particular case, it was ESBL. So that is something you have to be always remembering. If somebody had a prostate biopsy or urological procedure, sometimes after that, you get this transient bacteremia. So I know we have the board review questions, Neha. Before that, I will make a few points. I mean, you did an excellent presentation, very thorough. Just a few points to make. The nitrofurantoin, it is a very good drug. I mean, as you mentioned, cystitis, the first line choice, it is nitrofurantoin. It's given for 5 days. Bactrim is given for 3 days, and fosfomycin is 1 day. So 5-3-1 rule. So the nitrofurantoin, it is a great drug for E. coli cystitis, and it's usually good for prophylaxis, but it has inadequate levels in the tissue and blood. And we have to be mindful that the nitrofurantoin is intrinsically resistant to Pseudomonas proteus and Serratia. So if you have those bacteria, we cannot use the nitrofurantoin. And the resistance frequently described in Klebsiella and Enterobacter. So in our hospital, we do sensitivity testing. So that can be used for guiding treatment. The adverse events, you pretty much covered everything. The fluoroquinolones, the side effects you already mentioned, the tendinopathy, the aortic aneurysm, QT prolongation, those are some, and the dysglycemia that we need to be thinking about. There are a couple of other entities that they are very important. There is a entity that is like emphysematous pyelonephritis. Usually in the imaging, you will see gas in the renal parenchyma. So in that scenario, we have to percutaneously drain the kidney. And, that is the treatment. If they are not stable, I mean, nephrectomy will be needed also. The emphysematous pyelonephritis is usually happening, mostly 95% of the cases occurs in people with diabetes. And there are some negative prognostic factors if they are in septic shock, if they have thrombocytopenia and renal failure. Those are all very bad prognosis. The usual organisms are E. coli. I've seen it with Klebsiella proteus. So the diagnosis is often delayed because it is, unless you do imaging, you won't find that. And radiology is very helpful in that. And there is another entity is yeah, so another entity is called, it's very rare. It's a xanthogranulomatous pyelonephritis, and there has been description case studies for that. That is more like a chronic infection of renal parenchyma. And usually these patients have stone or obstruction, and it requires nephrectomy plus antibiotics. So that is also something you have to remember. Okay, great.
Thank you, Dr. Gopal.
Mhm.
Alrighty, so now we'll move on to the board review questions. So I think I have 5 questions here, 4 or 5 questions. So the first question is, 26-year-old female presents for a 3-day history or with a 3-day history of urinary frequency and dysuria. She reports no fevers, chills, or back pain. She says she is monogamous with a male sexual partner, and she has had 2 UTIs in the last year for which she took Bactrim. The last time she was treated was 2 months ago. She also takes OCPs and has no medication allergies. On physical exam, vital signs are normal. She has mild suprapubic tenderness with no CVA or abdominal tenderness, and the UA is positive for leukocyte esterase and nitrites. Which of the following is the most appropriate initial treatment?
I'll go with C, Bactrim.
Okay.
She take OCV, has no medication allergies.
Dr. Gopal, do you have any thoughts?
The last time she was
About,
treated.
I mean, this is yeah, so this is cystitis. So we talked about it, the treatment choices. So we have this patient already got Bactrim. So she took Bactrim twice. So as we discussed, like the treatment choice is nitrofurantoin for 5 days. That is one choice. The second choice is Bactrim for 3 days. And the third is the fosfomycin. So this patient already took Bactrim twice. So there is a chance.
Sorry, yeah, that's true. The nitrofurantoin, yeah.
Yeah.
Okay, so that is the answer B, nitrofurantoin, 100 milligrams PO BID for 5 days. And so this is the most appropriate treatment because she has an uncomplicated UTI, and this is treated based on the susceptibility of E. coli. So the first line antibiotics should be used to minimize any risk of resistance and development of adverse effects. So again, the first line agents are nitrofurantoin for 5 days, Bactrim for 3 days, and then fosfomycin as a single dose. So because this patient was recently treated for a UTI with Bactrim, it should not be readministered for reinfection within 3 months of a previous treatment. Okay, so question number 2, 83-year-old female with history of dementia and type 2 diabetes who is a long-term care facility resident presents to the hospital. Her caregiver states that she has become more confused over the last 4 hours. A routine UA performed on a catheterized specimen reveals pyuria, and a urine culture grows E. coli. The patient has no fever, flank pain, or systemic symptoms. Which of the following is the most appropriate next step in management? So A would be start empiric treatment with ceftriaxone. B is start empiric treatment with nitrofurantoin. C is obtain a CT of the abdomen and pelvis. And D is to assess for other causes of mental status change and observe.
So patients, she became more confused recently. But even if she doesn't have any urinary symptoms, it's still we can consider it as an E. coli. I mean, she didn't have any systemic symptoms, so we treat it as probably acute cystitis. So I'll go with the A, start empiric treatment with the ceftriaxone.
Okay.
Okay. So this is, there are two things, right? One is the board question and real clinical practice. The different aspects to it. So this is, first of all, this is a board question. So this patient has no fever, no flank pain or systemic symptoms. So IDSA guidelines does not, recommend any treatment for this type of scenario. So for the board question, the right answer would be just observe and assess for mental status changes and observe. That would be the one. I can tell you in real life scenario, we see the patient and this patient may have a wound, elderly patient. It depends on where the patient is coming from. So we would do blood cultures and, do evaluation. But this IDSA guideline does not recommend any treatment for asymptomatic bacteria because of the risk for the C. diff is high.
Yes.
So the key in this is like they're clearly saying there is no flank pain, no fever, no symptoms, and just confusion by itself is not an indication for treatment.
Right.
And in real life scenario, we have to assess, is the patient having any history of prostate enlargement? So many things we will be assessing in real scenario. So
exactly. So in real life, there's definitely more factors to consider. But in this case, just a mental status change in an elderly patient can have many other non-infectious causes, and asymptomatic bacteria is common in elderly individuals and long-term care facility residents. So according to the IDSA guidelines, treating asymptomatic bacteria in this population is not recommended and doesn't improve outcomes. It can increase risk for C. diff or antimicrobial resistance or adverse drug effects. And if the patient had a fever and any other signs of systemic infection consistent with sepsis without a localizing source, then broad spectrum antibiotic therapy can be used. And so third question is 75-year-old female presents with a history, or 75-year-old female with a history of hypertension and CHF is hospitalized for acute decompensated heart failure. An indwelling urinary catheter is placed to monitor hourly urine output, and IV diuretics are administered. Medical history is significant for hypertension and untreated urinary incontinence. Her medications are carvedilol, furosemide, and lisinopril. On physical exam, she's hypertensive and tachycardic. She also has bibasilar crackles and bilateral lower extremity pitting edema. Which of the following is the most appropriate management to prevent a urinary tract infection? So A is administer prophylactic Bactrim. B is check a UA and a urine culture on the third day of catheterization. C is remove the indwelling urinary catheter. And D is replace the indwelling catheter with a new antiseptic coated catheter.
I'll go with C, remove indwelling urine catheter.
Yes.
good job. As infectious disease physicians, we love to remove
Yes.
everything.
Yes, exactly.
Yes.
So these patients, so female patients that are older than 50 years are at increased risk for catheter-associated UTIs. Without indication for an indwelling catheter, it should be removed. And accurate urine output monitoring in a critically ill patient is appropriate, but this patient is not critically ill. Antimicrobial or antiseptic coated catheters can decrease the incidence of asymptomatic bacteria, but they have not shown any decrease in catheter-associated UTIs with short-term catheterization.
Okay, I think we have 3 minutes left. So
Okay. 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 Should we do one more question or should I just skip to the summary?
yeah, go ahead and quickly we can do the questions. Yeah.
Okay. So 34-year-old female evaluating the ED for 3 days of dysuria and urinary urgency and frequency with 1 day of fever and left flank pain. She reports no nausea or vomiting. Medical history notable for a UTI infection 2 months ago and was treated with Bactrim. On physical exam, she is febrile. She has normal blood pressure, pulse is 100, mental status is normal, abdominal palpation elicits suprapubic tenderness and CVA tenderness on the right side. Labs significant for leukocytosis with the UA positive for leukocyte esterase and pyuria. Urine culture is pending. She's given 1 dose of ceftriaxone in the ED, and clinical improvement is noted following Tylenol and IV fluids. She is tolerating oral medications and will be discharged. Which of the following is the most appropriate treatment?
I mean, it seems that she started having your she got the Rochef, and
Mhm.
I would go with the um, I believe here we'll go with the Cipro, maybe cover for Pseudomonas. Go for B.
Yeah, so B is correct. So the most appropriate treatment is Cipro. These patients with acute pyelonephritis can be managed in the outpatient setting with oral antibiotics, but hospitalization should be considered for any patients with hemodynamic instability, obstructive disease, pregnancy, or any complicating comorbidities. Fluoroquinolones are the only oral agents that are recommended for empiric outpatient treatment, and an initial dose of long-acting parenteral antibiotics like ceftriaxone should be given before the fluoroquinolone course is started. Okay, so in summary, UTIs are very common in men and women. They're usually caused by E. coli. There's differences between a simple versus complicated UTI, and complicated UTIs present with systemic symptoms. It can be diagnosed with clinical features, but the diagnosis can be supported by UA and a urine culture. For simple cystitis, the first line is treating with nitrofurantoin, Bactrim, or fosfomycin. And outpatient complicated UTIs can be treated with Bactrim, fluoroquinolones, and Augmentin. Inpatient management of UTI depends on the UTI complications, risk factors for MDR, clinical illness, or culture results, and what the patient can tolerate. And the duration of antibiotic therapy should depend on each case, but generally, simple cystitis is 3 to 7 days.